Hello people, so welcome back to my channel Learn with Dr. Akshatha. So this channel aims to make difficult topics simple. So today let's start with a new series, Opportunistic Infections in the PLHA patients or HIV patients. So for those of you who don't know me, I am Dr. Akshatha, currently pursuing my DM infectious disease in AIIMS Jodhpur. So without further ado, let's get started. So I'll be discussing this topic in this heading, the epidemiology, the clinical diagnosis, the laboratory diagnosis, the treatment, and the very important question, when do you give ART in a patient having PLHA and who is having concurrent opportunistic infection, and the prevention. So when we look at the epidemiology of opportunistic infections in low and middle income countries, so the most common one, the most common group is your oral candidiasis, in that oral and esophageal candidiasis, followed by your PCP and herpes. And next is your next group belongs to your TB. Mostly it is the extrapulmonary TB which is predominant over the pulmonary tuberculosis. Then your herpes zoster HSV infection. So these are the most common one which are there in patients who are not on ART. In the patients who are started on ART, the overall disease burden or the opportunistic infection burden is reduced. So as we can see, but still among them the most common ones are your tuberculosis, which could be disseminated, and most commonly it is extrapulmonary TB followed by your pulmonary TB. So when we look at the same situation in India, as such there are no common study or multi-center study which is available. So there are available as case reports and so they are available as discrete case reports and original article in the hospital, in the local hospital. So among them, the most common one is the tuberculosis, followed by your candidiasis, diarrhea, and others. And this is one which has analyzed the various spectra of the opportunistic infection. Again, the most common one is your extrapulmonary tuberculosis, followed by a pulmonary tuberculosis, then oral candidiasis, herpes zoster, etc. So like this, there are various discrete studies, but no benchmark or multicentric study which is available in this regard. And one more important thing for predicting the opportunistic infection is the CD4 level in the patient. So as soon as a patient is diagnosed to have a PLHA, you need to screen few things. First and foremost, apart from your the HIV testing, your CD4 count and your HIV viral count. Why? Because based on the CD4 level, you will be screening for the opportunistic infections as well as giving the appropriate prophylaxis. So when the CD4 count is normal, mostly it is your community acquired organisms which are most likely to cause the infection, which includes your bacterial pneumonia, herpes zoster or zoster reactivation. 200 to 500, tuberculosis is the most common. And when it is less than 200, it's your PCP, cryptosporidium, candida, and fungal pneumonia, which you need to be worried about. And when it is less than 100, your toxoplasmosis, candida, and basically esophageal candidiasis, HSV, CMV esophagitis, these are more common. And when it is less than 50, your CMV, Cryptococcus, Mycobacterium, avium complex, MAC infections, disseminated MAC infections, and primary CNS lymphoma, these are relatively common when the patient is having CD4 count less than 50. So today I'll be discussing about the treatment of various opportunistic infection. So I'll be discussing it as a series. So every different opportunistic infection one will be uploaded one by one. So and most of the guidelines is from the guidance for prevention and treatment of opportunistic infection in adults and adolescents with HIV. This is a recommendation from CDC and NIH and HIV medicine. Also, I've taken some part from the British HIV Association BIVA guidelines as well. So first, as we will begin with the case, a 65-year-old male newly diagnosed PLHA who has not yet started on ART presents to your ID clinic for screening for opportunistic infection. When inquired, he had history of fever which was high grade and not associated with chills and rigors. And this fever was intermittent, and this was associated with difficulty in breathing. He gets the report CD4 count is 1, just 1, and his HIV RNA is quite high, it is 3,40,000, and sputum CVNAT was negative, which was done as a part of ruling out the opportunistic infection. And on examination, there was pallor present, oral thrush, and he had chest examination showed bilateral normal vesicular breath sounds. Chest X-ray was done and it was suggestive of interstitial reticular infiltrates. So what will be a provisional diagnosis? So with the patient having CD4 of 1 as having fever with difficulty in breathing and chest X-ray suggestive of interstitial infiltrate, first and foremost you should be alert is your PCP pneumonia, that is Pneumocystis carinii pneumoniae. Then cryptococcal pneumonia closely mimics your PCP pneumonia. So hence you should always screen the patient for cryptococcal pneumonia as well. And TB, as we all know, is a great mimicker, so it can present to you with any situation. So TB, it can't be ruled out, so it should also be considered. But again, sputum CBNAT is negative, it's mostly unlikely, but still it will be in your DDs. So whenever a patient, PLHA patient is coming with respiratory distress, so what are the things we should keep in mind? As I mentioned, again depending upon the CD4 count, you will have to, you can narrow it down slightly. So in HIV bacteria, as per the community acquired bacteria, all of the community acquired pneumonia can present in that, like Streptococcus pneumoniae, Haemophilus influenza, staph, etc. Apart from that, MAC or NTM is also more common in HIV. Fungi, first and foremost is PCP, Cryptococcus neoformans, and Cystoplasma, Aspergillus, and other dimorphic fungi like Coccidioides imitis, Blastomycetes dermatitis, etc. Parasites, again, parasites can also present with respiratory disease, that is your Toxoplasma and Strongyloides cercoralis. Viruses, CMV pneumonia is also a known entity, and when the CD4 count is less, you should also keep in mind about the CMV and influenza virus, and obviously current situation COVID-19 as well. And COVID-19, again one more issue, the COVID-19 presenting with respiratory distress or pneumonia is quite rare because the patient is already immunocompromised, and as we all know, COVID-19, the disease or pneumonia causing is due to the cytokine storm, which won't be usually present in the HIV patients. Non-infectious, again this also has to be kept in mind. It is not necessary that all are infections. So that could be a carposis, sarcoma, lymphoma, lung cancer. So again, as I mentioned, based on the CD4 count, again your DDs can be narrowed down when it is CD4 count is less than 50. MAC, CMV and fungal infection you should keep in mind. When CD4 is less than 100, bacterial Pseudomonas toxoplasmosis kaposi. CD4 less than 200, PCP, TB, but which is often disseminated Cryptococcus pneumoniae. So when the CD4 count is less than 200, all of the DDs will be coming. Any CD4 count, it is more likely to be a bacterial pneumonia or TB. So this is a flow chart which I have tried to make based on the respiratory symptom when the patient is having some respiratory symptom and chest X-ray. If the chest X-ray is normal and the patient is normal, it could be non-pulmonary cause or upper respiratory tract infection, acute bronchitis. If the patient is ill, you will have to the patient should undergo HRCT. And if now the patient chest X-ray shows features of consolidation and it is acute picture, you can think of pyogenic bacteria. If it is subacute, you should look for TB and nocardia. If there is diffuse interstitial infiltrate and acute presentation, Pneumocystis zeroki, and bacteria, especially your Haemophilus influenzae. In case of chronic, as mycobacteria, which could be TB as well as NTM, fungal pneumonia, especially Cryptococcus, Toxoplasma. So whenever, this is one important clue is whenever a patient who is diagnosed to be PLHA is presenting to you with spontaneous pneumothorax, you should always and always exclude PCP in such a patient, because it is highly diagnostic of your PCP pneumonia. Next, if there is cavitatory infiltrate and it's acute presentation, you will have to look for Staphylococcus aureus, fungi, anaerobe, subacute, again tuberculosis and nocardia, alveolar pattern, acute situation, bacteria, subacute, it could be TB, PCP and non-Hodgkin's, miliary, obviously first and foremost is your TB. Apart from that, other dimorphic fungi like histoplasma and coccidioidomycosis. One important fact is, it is very common in a PLHA patient to have co-infection of TB and histoplasma, which is usually not looked into. As well as then if it is a patient is having nodules or lymphadenopathy, TB, fungi as well as bacterial fungi can be cryptococcal or aspergillosis. If it is non-infective or it's a chronic presentation, you look for non-infective causes like non-Hodgkin's and or bronchogenic carcinoma. So getting back to the patient, his serum cryptococcal antigen was negative. So this rules out almost your disseminated form of cryptococcus. As I have discussed in my previous class or we play on cryptococcus. So cryptococcus, initially the lesion, the presentation, it is pulmonary followed by dissemination, where your that time dissemination occurs through the blood. So your serum will be positive, then disseminates to the brain causing cryptococcal meningitis. So if serum cryptococcal antigen is negative, it is almost unlikely to be causing your pneumonia, causing disseminated infection. Again, it is better that you do respiratory sample cryptococcal antigen testing to confirm this. Sputum Sabinat was done, which was negative. BAL, so the patient was planned for BAL. So in the meanwhile, the patient CECT was done, which was suggestive of ground glass opacification predominantly over the central region, that is the perihilar region, and there was few cysts in the right upper and middle lobe. So this ground glass appearance or the opacities in predominantly perihilar region is quite suggestive of PCP. His BAL CBNAT was negative. And so this was the BAL sample which was subjected to the immunofluorescence, which was showing this, as well as your Gomari Mithmin silver staining showing your typical ping pong ball appearance. So this was a case of Pneumocystis pneumonia. So what are the risk factors? So when should we be suspecting PCP? So whenever a patient who is having oral thrush and unintentional weight loss and having high plasma, high HIV RNA levels, then you will always have to look for PCP, and it is usually having subacute onset with the progressive dyspnea, fever, non-productive cough and chest discomfort. And one feature which is very predominant is hypoxemia. Hypoxemia or low blood oxygen level is the most characteristic abnormality, lab abnormality you can see. And one laboratory finding or the biomarker which you can use is your LDH. Usually PCP pneumonia patients will have LDH of more than 500. And in the early disease, normal chest x-ray. And even if the patient is having infection, around 30% of the patients will have normal chest x-ray. So the typical feature is your diffuse bilateral symmetrical ground glass interstitial infiltrates from the hila in the butterfly manner is a typical picture. If the CT scan is negative for your GGOs, then it has a high negative predictive value, so it can easily rule out your PCP pneumonia. So for the next, coming to your diagnosis, so what is the sample you will use and what is the sensitivity? The sample, usually the patient with PCP pneumonia will not be having sputum production. Hence, it is necessary to induce the sputum. The sensitivity of it is around 50 to 90%. BAL is a very good sample. Again, usually because most of the patient of PCP pneumonia will be coming with severe distress, and the patients will be admitted in ICU, making it a little difficult sample to be collected. Lung biopsy has almost 100% sensitivity. Again, it is one of the so it is very difficult to obtain the sample. The spontaneously expectorated sputum, even if the patient is able to produce, has low sensitivity, hence it should not be used. And what stains you can use? Giemsa, Diffquick and Wright stain can be used. This will stain both cystic and trophic walls, but they do not stain the cyst wall. And Grocott, Gomery, methenamine silver, Graham Wright, Crescel violet, Tolidine blue. So Tolidine blue is the staining method of choice which is usually suggested, these will stain the cyst wall. And as I mentioned, Gomery, methenamine silver will have the typical ping pong ball appearance. Immunofluorescence test, this is one of the easy tests which can be done, but unfortunately it is not available in most of the labs. So this has a better sensitivity and specificity compared to your other staining methods. Then PCR, so you can even do PCP PCR, but it can't differentiate colonization from infection, and PCP pneumonia is associated with elevated beta D glucan, so it can be used. So this is a table showing the various sensitivity and specificity. So the microscopy test, so you can see the Gomery methamine silver has the better sensitivity, whereas Tolidine blue has the highest specificity. Again, as you can see, the specimen BAL sample has the higher specificity. Giemsa has around 75%. Immunofluorescent assay, which is done on BAL sample, has almost 100% sensitivity and specificity. Then molecular method, so PCR, though it is very sensitive and not specific, has a good specificity, but as I have mentioned, it is difficult to differentiate colonization from infection, and as usual it is not available in most of the labs. When you look at the serological or biochemical markers, so beta D glucan can be used. Then LDH also can be used. As I mentioned, LDH usually raised in patients above 500. So how do you stratify the patient once the patient is diagnosed with PCP, having PCP pneumonia or Pneumocystis carinii pneumonia or Pneumocystis jirovecii pneumonia? So how will you classify? So it is classified as mild, moderate and severe. So based on the symptoms. So the patient usually will have dyspnea on exertion, and is oxygen PaO2 or on room air is more than 83, or SaO2 of more than 96 is classified as mild PCP. Moderate is when the patient PaO2 is between 61 to 83 or SpA2 of 91 to 96, and severe when the patient is having PaO2 of less than 60 and SaO2 of less than 91, showing extensive interstitial shadowing without diffuse alveolar shadowing. So you need to stratify the patient to mild, moderate or severe. So why do you need to stratify? Again, because the treatment depends upon the stratification. And what is the treatment of choice? The treatment of choice is cotrimoxazole for a duration of around 21 days. And in case of moderate to severe disease, you should add adjunctive corticosteroid as soon as possible, at least within 72 hours after starting the PCP therapy. Why? So this is the reason I have mentioned before, that the patient has to be stratified into mild, moderate and severe, and this moderate to severe disease only patient should receive the adjunctive corticosteroids, and there is no value of adding leucovorin, uh, because there is some evidence which will which has showing that higher failure rate in preventing PCP as well as efficacy in preventing this toxicity is questionable. So, and in this patients with PCP, so when do you start the ART? It should be started at the earliest, but not within first week. So between first week to 2 weeks after initiating the treatment of PCP is the ideal time. So if you delay more than 2 weeks, it is associated with higher mortality. If it is given before 1 week, again it is higher associated with higher mortality. Hence between 1 to 2 weeks. So again, this is the treatment. So for moderate to severe PCP, total duration of treatment is 21 days. The treatment of choice is cotrimoxazole. So in that, which is given every 6th or 8th hourly. And alternatives include your clindamycin plus primaquine, or clindamycin plus dapsone or pentamidine. And what are the adjunctive corticosteroid recommendations? So when the patient is having PaO2 of less than 70 or alveolar arterial DO gradient of more than 35, in that case you have to add the prednisone. So it should be added as soon as possible, and the treatment, there is a difference. So for day 1 to 5, the patient should receive 40 mg PO twice daily. 6 to day 10, the patient should receive 40 mg PO OD dose, then 11 to 21 till the cotrimoxazole is going on, the patient should receive 20 mg daily. If at all you are using IV prednisolone, then it can be given as 75% of the prednisolone dose. And how do you give this? So it is recommended that before you give the PCP, that is cotrimoxazole, 30 minutes before that you have to give the steroid. So next important topic is your iris, or so there are two types of iris, as we know, the paradoxical iris or the unmasking type of iris. Paradoxical iris is quite rare in PCP. Unmasking type, that is the patient was not diagnosed to have PCP, was or what not looked for having PCP. So patients was started on ART. Now he is having presenting with features of PCP, that is he had PCP before which has got unmasked because of the immune reconstitution. So how do you diagnose? So fever and recurrence or exacerbation of the pulmonary symptoms he had, that is cough or shortness of breath, or worsening of a previously improving chest x-ray. So in that is when you will be identifying this. And again, the management of PCP associated iris is not very well defined, and the treatment of choice corticosteroid is the treatment of choice for your PCP associated iris. So next is your preventing disease. How to prevent the disease? So when to start the secondary prophylaxis? So there are two types of prophylaxis. Primary prophylaxis. So as we all know, for primary prophylaxis, whenever the patient newly diagnosed PLHA is having CD4 count of less than 200, the patient will be started on PCP prophylaxis, that is Septran or the cotrimoxazole double strength dose, OD dose. So that is your primary prophylaxis, that is to prevent the disease. So once the patient has had a PCP infection, you will give a secondary prophylaxis to prevent the reinfection or to prevent the relapse. So this should be initiated immediately upon completion of PCP therapy, and it should be maintained till immune reconstitution. And when will you stop the secondary prophylaxis? It will be stopped when the patient has CD4 count of more than 200 as for more than 3 months as a result of ART. So patient should be on ART, and CD4 count should be more than 200 for at least 3 months. So when will you restart the primary or secondary prophylaxis? It will be restarted whenever CD4 count is 100, irrespective of HIV viral load. If a patient has an episode of PCP and the CD4 count is less than 200, the patient should be given lifelong prophylaxis. So for preventing or the primary prophylaxis, so the indications is CD4 count less than 200, CD4 percentage less than 14% of the total lymphocyte count, and the patient if having more CD4 count more than 200 and but less than 250 and the ART initiation is delayed, then the CD4 count is not monitoring is not possible, then you have to initiate this PCP primary prophylaxis. As I mentioned, cotrimoxazole 1 DS tablet PO daily is recommended. Alternatively, cotrimoxazole one single strength tablet also can be used, or cotrimoxazole 1 DS tablet per orally thrice a week can also be used. Dapsone also can be used, etc. So these are the treatment or the prevention dose of your PCP. So I hope I have covered most of the PCP and had tried to keep it short. So thank you. If you like this presentation, don't forget to like, share and subscribe to my channel. So let's meet next week with the next opportunistic infection. Thank you.